to the last talk. I think that is something that we all are waiting to hear, for Dr. Rajalakshmi to sum up all these studies and tell us what we need to take home at the end of the day.
Thank you, Sheena. I'm not very sure whether all of us have simplified this or confused you more. Anyway, we'll have the maestro here, Rajalakshmi, to decode whatever is there in Smart India study and give us some take-home points. Over to you, Dr. Rajalakshmi.
That's very modest, Sain. I know that it has been a team effort in Smart India. It has not just been involving all these 20 sites, bringing them together. It has been a great teamwork, and if teamwork continues, we'll have more such studies coming out like the Smart India. And coming to these take-home points, see, all have to work together because India right now has over 100 million people with diabetes, and blindness due to diabetic retinopathy is preventable. So these are the things that we want to know, how what Smart India has, the lessons that we can learn from Smart India. In Smart India, we did not want to look at national prevalence of diabetic retinopathy or diabetes. We wanted to know what is the most cost-effective model, what is the most accurate, simple model which can be used to detect diabetes and diabetic retinopathy. So this possibly is the first study. There has been the S-Dream study, there has been the KSOS study, but this is the first study on national prevalence of diabetic retinopathy, which involved 4 main centers, 20 hospitals across India, with doyens from each and every center who participated as principal investigators to assess the burden of diabetic retinopathy. It is not easy without the cooperation from all these people who have their own patients practice to get involved in such a major study with such a large sample size across the country. See, here you can see the names of all the big people who have been involved in this study, and this also led on to the India Retina Specialist Group, which also got involved in doing more studies over the course of time. So what is the main point that we came to know from the diabetes thing is that 30% of them did not know they had diabetes, and even those who had diabetes had very poor control. 3/4 of them had suboptimal glycemic control, which is the most important factor other than duration of diabetes for developing vision-threatening retinopathy. So from the diabetic retinopathy paper about which Dr. Mahesh Dr. Mahesh Gopalakrishnan spoke, was that the prevalence of diabetic retinopathy in India, because we say more than 100 million people have diabetes, 12% itself means that there are 13 million people with diabetic retinopathy and 4 million people with vision-threatening retinopathy across India, and we don't even know how many of them have actually met the ophthalmologist. So to look at some of these points, we see that undiagnosed diabetic retinopathy is 8%. So many people who don't even know that they have retinopathy, so they have not gone and met an ophthalmologist to get their eyes checked. So 4 million people with sight-threatening retinopathy is a big problem, and you can see that both urban and rural. Earlier we thought diabetic retinopathy also occurs only in urban people, but we find that here in rural areas also retinopathy is as highly prevalent as what it is in urban areas. After the Smart India study got over, there was in fact questionnaire shared with the Smart India population because the study got abruptly ended. So this also assessed not only just how their mental depression and loneliness was also assessed. We did not give up on the study easily. Later we had the Smart India 2 study, which wanted, as the AI system wanted more number of STDR images, the handheld cameras were used to capture sight-threatening DR images. And after we detected vision-threatening DR, it was noticed that not many, as I rightly told you, were aware and went for eye treatment, possibly because it also involved an expense to go for vision-threatening DR treatment. So Samarth conducted a qualitative analysis to know what were the barriers which prevented them for undergoing treatment towards STDR. So what are the main take-home points which we have seen so far? Even trained, unskilled field workers can easily be utilized. They were utilized for the study. The study was not conducted by ophthalmologists. Point-of-care devices like point-of-care HbA1c, handheld cameras, everything could be easily be used for community-based screening. Non-mydriatic handheld cameras were reasonably easy to use. They could yield good images. There were challenges in upload of images whenever there was no internet connection, image quality, grading of images, and suddenly on the top of it, the study had to be abruptly stopped due to COVID. And also what was important that we realized, what not people who were detected and informed that they had vision threatening DR went and met the ophthalmologist immediately for further treatment. It is essential not to just screen, but we have to close the loop by treating those patients who are detected with sight-threatening retinopathy. We do understand that there is a large burden of diabetes and diabetic retinopathy which needs to be handled, and it's possible only with teamwork. Here what we wanted to see was, I work in a diabetes hospital where we have the Remedio fundus on phone cameras, which are smartphone based cameras. So Dr. Shobha was interested in seeing if this model of teleophthalmology actually works. We also do use these cameras in camps whenever we do camps, and we also use it for our home care patients where in our field, when our nurses go to the homes and take fundus photographs. So here what we have 50 branches. Dr. Mohan's Diabetes Specialty Center has 50 branches across India, and here the images are taken, and then we are a team of 7 ophthalmologists at the main center. We look at the fundus images and we send the reports real time, even before the blood test reports which were taken in the morning go out to the diabetologist. The eye reports will also be available with the diabetologist. So the diabetologist will know if the person has retinopathy when they see the patient. So if they have retinopathy, they will be advised FFA, OCTs, etc. Those with no retinopathy will be asked to come back after 1 year. So we found that this model was quite effective, and it could detect over 30% retinopathy. This was again in over 60,000 patients in which this study was done. Dr. Shobha initiated this idea, and it was a part of the Ornet India project. So as Dr. Sheena rightly mentioned, just humanly grading all those thousands of images is not going to be practical. So we need an artificial intelligence as a solution. As she rightly showed in her paper, despite the image quality, the retinal images did show that the deep learning model showed a high sensitivity and specificity for even with 2 field images with a high AUC of 0.99. So artificial intelligence is the role when we have a large number of people to be screened for diabetic retinopathy. But is it possible to take retinal photographs for all the 100 million people with diabetes in India? Is it going to be possible? So I think targeted screening, about which Dr. Thomas spoke so well, that is what I'm going to again highlight here. Cystatin C, as he rightly mentioned, can be increased in people with kidney disease. But the study about which he told found that cystatin C outperformed 12 other biomarkers in significantly distinguishing sight-threatening DR from no DR. After this study was done by Shankar Nethralaya, Arvind and group, we did the external validation. Giridhara Institute and we were involved, and we did the external validation. And then we found that sight-threatening DR can easily be detected using cystatin C. So teleophthalmology is useful, use of AI, cystatin C, biomarkers. So what are the practical recommendations? We have to strengthen the NCD clinics. We have to build the capacity of ASHA workers, or we have to train and more field workers. Integrate technology like use of AI and teleophthalmology. These models have to be tailored in the sense that focus on high risk group, focus on the states like India, Tamil Nadu and Kerala, which have high diabetes and retinopathy. Increase awareness about vision-threatening DR. The government has to have a national diabetes database, national diabetic retinopathy database. Government has to focus to reduce the cost of treatment for vision-threatening DR. So with the use of innovative technology, point-of-care devices, smartphone cameras, teleophthalmology, AI, novel biomarkers, it is definitely possible to improve DR screening and to reduce avoidable blindness due to diabetes in India. Thanks for your attention. This is our team. This is the Smart India team.